And so let's go ahead and let's take a look at what's going to happen to the quote unquote mommy during pregnancy here. And so we're going to start with before conception, where we have normal orientation of the uterus, normal growth of the mammaries. We will get engorgement of the mammaries during the first trimester. The engorgement here is due to hyperplasia and hypertrophy of the lobular tissue. We get enlargement of the uterus. We get a slight change of musculoskeletal anatomy, and we start getting a change of physiology and metabolism as we start moving towards that resistance phase that we'll see in terms of physiology when we start looking at the various systematic changes. Now, notice the big change here as we move towards the second into the second trimester here. We get rearrangement of the abdominal pelvic cavity. We get a change of lower lordotic curvature within the lumbar spine. We get continued hypertrophy and hyperplasia of the mammary glands. As we move into the third trimester, we get continued growth of the uterus. We get rearrangement of the organs within the abdominal pelvic cavity. We get full maturation of the mammary glands in preparation for suckling and breastfeeding postnatal care. If we were to summarize what's going on, during the first 15 weeks, we get about 1.5 kilograms of mass growth. During the next phase, 16 to 27 weeks, we're going to gain about 7.5 kilograms. By the terminus of pregnancy, there will be about a 17 kilogram mass change. Of that 17 kilograms, 3 to 4 kilograms should come from the fetus. About a half to a full kilogram is going to come from the placenta itself. About a half to a full kilogram is going to come from the fetal side of uteral tissue. And then we have about 1 kilogram to 1.5 kilograms of fluid mass within the amniotic fluid. Within the mommy to be, we're going to have between a 0.5 kilogram and 1 kilogram mass gain within the breast, predominantly within the mammary glands themselves, but there will also be an increase of adipose tissue within the mammaries. This increase of adipose tissue is there to protect the glands, not to serve as a fuel source. We're going to increase blood from anywhere from 1.5 to 2 kilograms. Now, if you notice in terms of percentage, this increase of blood mass is equivalent to the same percentage that we would see in terms of total mass of gain. In terms of body fluids, we're going to see between 1.5 and 2 kilograms of fluid. In terms of body tissue, there'll be about 4 to 5 kilogram mass change of just body tissue. Most people will typically stipulate this is going to be fat tissue. However, it's not fat tissue. Most of this tissue is going to be fat-free mass, and most of this is going to be in bone and skeletal muscle, particularly bone and skeletal muscle that we see within the lower extremities, in response to having to load and resist additional mass during pregnancy. We're going to take a look at some of the system changes, and some of these changes that we see within the system leads to some normal recommendations in terms of dietary restrictions, physical activity restrictions. However, we have to be careful with some of these because they can lead to issues for metabolism later on. So in terms of respiratory, we're going to see an increase of respiratory rate, increase of tidal volume, an increase of minute ventilation with an accompanying decrease of vital capacity. We get a decrease of vital capacity late in this because of the changes within the abdominal pelvic structure, which is a pseudo-obesitic change where the ability to change the thoracic cavity is similar to what we see with someone who has obesity. This is going to lead to symptoms of respiratory alkalosis for the pregnant female. In terms of cardiovascular changes, we're going to see an increase of cardiac output. This increase of cardiac output is going to occur without a change of stroke volume. Stroke volume stays relatively stable. We get an increase of heart rate and to increase total cardiac output. The reason we're going to see an increase of total cardiac output is because we're going to see an increase of total blood volume relative to non-pregnancy. We see an increase of angiogenic signals leading to more blood vessels throughout the body. As we see an increase of more blood vessels throughout the body, we're going to see a relative reduction of total peripheral resistance early in pregnancy. However, late in pregnancy, we're going to start seeing a relative increase of total peripheral resistance as the fetus starts to grow in volume, increasing the volume of the uterus, compressing on the aorta within the abdominal pelvic cavity. These changes in peripheral resistance can become problematic for mommies-to-be that want to be active, as it can lead to exertional hypotension and exertional hypertension issues, leading to irregular baroreceptor responses and possible exercise-induced syncopes. In terms of the immune response, we're going to see a constant resistance phase. We're going to have high levels of IL-1, high levels of IL-2, high levels of IL-6, high levels of IL-10. We're going to start seeing increases of immunoglobulins to counter fetal signals. We're going to see an increase of non-adrenal inflammatory markers. And this is important here because if we start increasing adrenal inflammatory markers, we can induce birthing. We'll start seeing increases of intrinsic clotting mechanisms, which can become problematic and increase the relative risk for deep vein thrombotic activity. In terms of gastrointestinal functions, we're going to see a change of motility. We're going to see a relaxation of the esophageal sphincter, leading to increased risks for gastric reflux. We're going to see increases of constipation. We're going to see a reduction in the interluminal diameter of the intestines. We're going to start seeing increases of absorptions for calcium and lipids, which are necessary for the fetus. We're going to see a change in feeding regulation, and we'll get to that change in feeding regulation in a second here when we talk about changes of the nervous system. In terms of excretory functions, we're going to see an increased rate of micturition and a diminishment of clearances. We're going to start to have increasing of voids because of a reduction of volume available to the urinary bladder. We'll also see a change to sympathetic outflow, which is going to change the vascular flow within the kidneys, thereby reducing the rate of filtration and reducing the rates of clearance. However, we now have an increased volume that is necessary to be cleared. In terms of the neuroendocrine changes, we're going to see an alteration of hypothalamic outflow. This alteration of hypothalamic outflow is because the placenta takes over. Because the placenta takes over, part of what we see postnatal in terms of suckling and breastfeeding is the reconstitution of hypothalamic outflow. From the hypothalamus, we will see an increase of prolactin releasing hormone due to signals from the placenta, leading to an increase of prolactin, leading to hypertrophication and hyperplasia of the mammaries and production of lactations. We'll see a change of thyroid output. We'll see excessive amounts of T4, and that excessive amounts of T4 is predominantly for the fetus, not for the mother. We can see a possible change of insulin sensitivity based off of level of resistance that's taking place. And we will see a reduction of growth hormone production and release due to the placenta. In terms of the nervous system, we're going to see a change of the serotonergic and dopaminergic pathway. We're going to see a change of the reticular activating system, a change of prefrontal cortical functions, which is associated with oxytocin swings, leading to what's referred to as maternal brain. We will start seeing a change of mood due to mammary body activity and alterations of hypothalamic outflow to the amygdala, leading to overactivation of the amygdala. We're going to see a change of rate of logarithmic compressions within the central nervous system, which can lead to changes within the limbic system activation pathways, leading to issues with memory, learning, and recall. We will see a change of cravings and starvations as it relates to the short loop and long loop. Most of these changes of cravings and starvations have to deal with the reward center wants and the mammary body signals as it relates to fetal signals in terms of needed nutrients for fetal growth. And this will lead to the changes in what's usually referred to as pregnancy cravings, Because of the changes of the anatomy within the abdominal pelvic cavity, we'll see a change of satiations. Musculoskeletally, we'll see a change of joint kinematics within the lumbar and pelvic regions, including an increased lower dodic curve. We will see increased tension within the skeletal muscles, particularly those in the lower extremities. We'll see increased risks for cramping due to ion imbalance issues and overall hydration issues. Late in pregnancy, we can see a change of ligamentum tensions due to changes of relaxin signals, and this becomes problematic with increased weight for the pregnant female, leading to increased likelihood for subluxations and spontaneous dislocations, which can trigger the signals for bed rest.